10 o'clock, so I think I'm going to go ahead and kick us off. It's nice to see several of our clinical champions from our sites and some of our sons joining this call. So thank you all for being with us today as California Bridge joins many, many other organizations in trying something new virtually. So as everyone knows, we were supposed to be together about 2 weeks ago in Berkeley for our big April training. That was going to be kind of the big final training of the current round of hospital funding that we're doing. And we had to cancel that. So we've been working hard to figure out how to get you the information that we wanted to get to you in a meaningful way. So thank you so much for joining our inaugural attempt to do just that. The goal of today's training is to answer some concerns and questions that you brought to us via your responses to our COVID survey that we put out a couple weeks ago. So, let's see. There we go. Whoops. It's being a little bit slow on my end. Sorry about that. So just to go over what we're going to be talking about today. First, Dr. Hannah Snyder, who's on the line with us as a panelist, is going to be talking about what we heard from you through the survey results and talk about how we've heard some of your hospitals responding, what some of the pain points have been, and how we're recommending that you move forward, especially with some of the concerns about volume at your sites that we've heard from many of you. Then Dr. Amy Mulan should be with us. She should be joining to talk about what we are hoping to get from you in this new phase and how we're hoping to continue to support you and your journeys. And then we have two of our amazing substance use navigators who have some really interesting stories to share that I think will be helpful to both providers and other sons on the line in terms of how they've been able to successfully continue their work. And then we'll have plenty of time to hear from you and take questions. So there we go. Does it, is it still showing as presenting or is it showing as my browser?
Showing your browser.
Okay, I will fool with that. Okay, so before I have Hannah get started, this is some notes about how to use this Zoom feature. So if you want to drop a question in as we're moving through everything you hear from Dr. Snyder and from the Sons, you can use this Q&A function, and I'll be working with that. So right now there's no open questions, but go ahead and put your questions in. There'll also be an opportunity to unmute yourselves and ask questions or share stories live. Other than that, if you want to have your voice heard and speak on this call, which we very much recommend and would love to hear from you, you can raise your hand, and that's how I'll know to help you speak to us. So here's a little bit of guidance. Same if you're on your phone, you have the same options. You can contribute to the Q&A. You can raise your hand so that we can hear you. And if you have any questions about exactly how to use this feature, go ahead and you can let us know that as well using the Q&A function. And again, save the date. This is the first of 2 trainings that we'll have responding to your questions about COVID-19. And the next one is going to be specifically about telehealth nuts and bolts. So we know that that is something that's come up again and again, and many sites are looking for guidance about how to improve your telehealth programs and also how to get paid for them. So we are working behind the scenes to get that ready for you, and that is coming up 2 weeks from today, so May 19th at 10 a.m. Just keeping in mind, since there are several sons on the call, we do have 2 more pop-up trainings for you this month, and then those will continue into the later spring and summer. Now my screen advancement is working. There we go. So this is a note to talk to you about how we would love to have you staying engaged with us right now. And I don't think Amy has joined the call yet, so I'm going to move through this quickly and then have Hannah take over, and Amy might hopefully join us later in the webinar. I know Tuesdays are a challenging day for the physicians who work with Bridge. We really put them to work on Tuesdays. So this is We really want to be hearing from you right now. We really miss the opportunity to see you in person. Our regional directors miss site visits with you. Our Sun mentors miss site visits to your hospitals. And we want you to feel like we have opened doors for you to come to us, either directly to your regional director or directly to me at the program, to hear what's going on at your sites, particularly as we move toward the close of this round of the Bridge program and look toward what's coming next. So please use us as a resource. Call us up. We have a new form on our website where you can request any kind of technical assistance anytime if you're not exactly sure the best person to be talking to. We'll be sharing a contact sheet with you very soon. The Suns already have it, and that'll give you an opportunity to have direct links to other people doing work in this in your region and elsewhere in the state that you'd like to be networking with. Again, long-term strategic planning is underway for how we're going to be supporting you through this current round of funding and beyond. And just a reminder that our toolkit is always available at bridgetotreatment.org. So I'm so happy to have you all joining us today, and I hope that this is the beginning of a long virtual engagement until we can all see each other again. So I will turn this training over to Hannah. And Hannah, just let me know when you need the slides advanced.
Great. Thank you all so much for being here today. I mostly want to just respond directly to the concerns that you all had around volume. We're seeing huge shifts in our volume in the ED, in the inpatient setting, in outpatient setting, and we're really trying to think strategically about how we can best serve our patients in the setting of COVID. But before I dive all the way into it, some of you may have heard me kind of talk about this framework a little bit before, but I think we need to pause for a second and realize that our healthcare systems have been sprinting so hard to address the needs of COVID-19 patients that we have sometimes been not meeting the needs of our other patients. We know that people who use drugs and people who use alcohol have a lot of vulnerabilities to COVID-19, so they're uniquely susceptible, right? We have a lot of patients who are using drugs who are also experiencing homelessness, or who are living in congregate living environments like shelters, like encampments, like residential treatment programs or detox centers. All these are places where COVID can very rapidly spread, and we've seen that happen across the state of California. We also know that our people who use drugs have a lot of medical comorbidities. They might have cirrhosis, they might have COPD, they might have underlying heart failure, all of which can put them at risk for more significant COVID-19 when they do get it. And then we know that our people who use drugs have historically experienced a lot of stigma, have experienced a lot of racism, and have honestly just had bad run-ins with the healthcare system in the past, and so are going to be uniquely afraid of presenting into the healthcare system. So this is a population, if we truly want to stop the spread of COVID-19 in our communities, every hospital should be making a case for why it's next level important to be treating people who use drugs right now. So we can prevent that spread of COVID-19, we can prevent these really serious cases, and we can bring people into the healthcare system early to prevent that mortality. Next slide. We know also that COVID-19 has put our people who use drugs at increased risk for sequelae of their substance use disorders. So in the setting of quarantine or isolation, if somebody has a COVID-19 exposure, or even in the setting of just sheltering in place, we're seeing a lot of people sort of involuntarily go into withdrawal. So say folks are housed in a hotel. They may no longer have access to their drugs, and so they may be going into withdrawal at much higher rates than they would have been previously from drugs, from alcohol, from things like that. We're also starting to see a lot of disruptions in our supply chain, and there's at least rumors out there, patient reports, that there may be increased fentanyl contamination of the drug supply, and that the prices of the drug supply have gone up so much that people may be going to different sources than their usual sources, and therefore using in a riskier way. We also know that in some of our communities across the state, syringe supply distribution has been disrupted. We're lucky that we have many partners in our syringe supply sites who are remaining open, who are making sure that patients have access to harm reduction materials, but that's not the case in all of our communities. And so we're anticipating that we're going to see increased rates of skin and soft tissue infection, things like HIV and Hep C could potentially spike, endocarditis could potentially spike as a result of this decreased access to clean needles. And then we've also, historically given our patients this guidance on never use alone. If you're going to use your opioids, use them together with a buddy so that if you do have an overdose, they can use naloxone on you and call 911. Well, how does that work when you're sheltering in place by yourself? So we're anticipating and we're starting to see a spike in overdose deaths as a result of this. Next slide, please. This is a Kaiser Family Foundation survey that went out to just like assess how coronavirus is impacting people's mental health. And this is not specific to substance use disorder, but we know that people are having really significant mental health issues as a result of the anxiety of COVID, the social isolation of COVID, the sort of being in this pressure containment area with this small number of people that you may live with. People's mental health is really suffering. So we're seeing that with increased suicidal ideation. We're also starting to see that with increased return to substances for people who were in remission, and potentially overdoses for people who were in remission. So next slide, please. These are just anecdotal reports, but we're starting to see more headlines pop up around the country, and I'm certainly hearing this from you all, from other sites that I work with, saying that we are seeing a spike in overdose deaths as a result of COVID-19. We think there might be a couple things going on there. One, people are using alone, like I was saying. Two, their drug supply has been disrupted. But also, people are really reluctant to present to the healthcare system right now. People are scared of going to the ED, and they might not be seeking help when they would have otherwise done so. And then a lot of our existing programs, a lot of our outreach work, a lot of the community outpatient and residential programs have shut down, have stopped accepting patients. So this is a time when it's next level important for us to be doing that outreach to capture these patients and to help prevent these overdose deaths, not to just have blinders on and only be thinking about COVID-19, which is really tempting for us to do right now. Next slide. So these are some anecdotal observations that I'm hearing from you all. We are almost all across the board seeing decreased volumes in our EDs, in our primary care practices, in our addiction care practices, right? Less people are coming in. And we know that the people who do come in are really sick. You all are seeing this. You all have reported this to us. It takes a lot for someone to decide to come into the ED now, right? So if you just have a little chest pain, you might not come in, but when it gets really crushing and you've had a STEMI, then maybe you'll come in. So decreased volumes of patients, but really increased acuity of those patients. And we're seeing that particularly with substance use disorder. So we're seeing, relatively speaking, of the percentage of patients who are coming in, we're seeing increased overdoses. We're seeing increased, really severe withdrawal symptoms from both alcohol, opioids, benzos. And then we're actually also seeing lots of patients who have increased treatment-seeking behaviors. So I'm hearing from many patients right now that those who do come in are coming in because in the setting of COVID-19, they've been reflecting a lot on themselves, on their health, on their role in the community, and really what they want for themselves. This is sort of a wake-up call for a lot of folks. So we've got this increased acuity, we've got people who are increasingly interested in seeking treatment. We have to make sure that those services are available for them. Next slide. And so this is what you've reported to us, just to put out there. In that brief survey we sent out there before, about 15 of our sites reported that they had a decrease in patients seeking substance use disorder treatment through their ED. 4 said no change, and then 3 said they had an increase in volume. So what this really tells me is that patients might not be coming into your ED seeking treatment, but they are out there and they have the need, and we have to find a way to bring them into our services. So next slide. Okay, so how do we find them? Every system is doing this differently, and this can seem really scary to a department right now where we have sort of, over the last few weeks, really been trying to keep people away, to keep people from the exposure. But I think we need to switch that framework, and more hospitals across the country and across the state are switching this framework to say, no, there's a lot of really sick patients out there and they actually do need our help. So part of that is just kind of putting out there in the community that your emergency department is a safe place. Our EDs are some of the safest places that we have right now, with our relatively low rates of COVID, our really rigorous disinfecting protocols, and actually some EDs are incorporating telehealth even for patients who come in the door, so that those patients can be seen by a provider without necessarily a face-to-face visit. We also need to be putting out there that our ED is a welcoming place, so that for people who use drugs, you can come in. We're still happy to see you. We're still really eager to engage with you. There are a couple different ways we can do this outreach, and I'll go into these in a few more details, and then I'd love for this to become more of a conversation. So please put in the chat and the Q&A and what your experience has been about how you're engaging with these patient populations. But multiple of our sites have actually formed these innovative partnerships with either isolation and quarantine settings or homeless housing settings that have sprung up in the last month. So knowing that if a patient is housed in one of these hotels or in one of these isolation and quarantine sites, that the staff on site knows to monitor those patients for substance use disorders. And if they do go into withdrawal for something like opioids, they know to reach out to the hospital, they know to reach out to your son and to get them that buprenorphine. And then also multiple of our sites have started to engage with a mental health access line in their county to say, hey, we're here, we're available. If you have patients who call in who say that they're struggling with substance use disorders, you can send them to us and we'll have ready access to treatment. And this is really big because a lot of the outpatient programs out there have shut down, have said we're not taking new patients, we're only caring for the folks we have now. We as the acute care providers still have this responsibility to be caring for the population as a whole. Next slide. Our sons have a really invaluable role in this, and we're going to hear from a couple of our real son champions out there about how they've been doing this. But just big picture, we're hearing from many of our sons that they're really reaching out to the harm reduction organizations in their communities, street outreach teams for communities with large homeless populations, to sober living and residential facilities, to EMS, and all of these sites, they're telling, hey, we're still here, we're still available. If you hear of a patient who has opioid use disorder, who needs our help, you can either bring them in to us or you can connect them to us through telehealth and we'll reach out and make sure that they're taken care of. And then many of our sons are actually going back through our prior patients because we know this time of COVID-19 is a really high time for relapse because of these mental health struggles that patients are facing. So many sons are going back through, calling their prior rosters of patients, checking in, just seeing how are you doing? How have you been? Are you worried about relapse? Have you relapsed? Can we help you with anything? Next slide, please. So I want to just show you a couple sample workflows of what this is looking like at different hospitals. And we're really going to dig into all of this on the next training on 519. But this is a workflow that's been set up at Highland Hospital. So Highland works with all these different sites in the communities, the jails, the detox, harm reduction, FQHCs, patient self-referrals, and they have a consolidated line where the patient can call the substance use navigator directly Monday through Friday during business hours. And the substance use navigator can actually kind of like bypass that first step of an ED presentation that we usually have, and instead register the patient, set them up for a telehealth visit, and then run those, and then connect the patient to a provider who is on call, who can take care of that patient and who can do a buprenorphine initiation. Because we know that the regulations have now changed such that you do not need a first face-to-face visit prior to initiating buprenorphine. You can actually do that first visit by either phone or by audio-visual connection. Next slide. This is some of what we're doing in San Francisco, based out of the city and county. We have a line that is, so the Highland line, patients can call into directly. The San Francisco line is provider contact based. So there are nurses at isolation quarantine sites, there's primary care providers, urgent care providers, all of whom can page directly a 5-day-a-week on-call pager to set up a telehealth visit with a patient who's in front of them. We also have a service available where we've been working with the substance use warm line, such that if they get a call from a provider in our county, they can connect that provider to us directly. And we can then, through that telehealth pager, register the patient into our system and then conduct a telehealth encounter that's staffed by our addiction medicine trainees and attendings, where we do a full history and intake, and then we do a same-day prescription, and the patients do a home start for their buprenorphine. And they can then follow up with us either by phone or in clinic. Next slide. And this is, I know this is out of the state of California, but this is a really innovative model that we're seeing out of Rhode Island, where it's a much smaller state than California. So they've been able to do a sort of centralized 24/7 actually buprenorphine access line. And we're thinking about this possibility for some of our counties in San Francisco as well. So they have a direct patient call system where they've put this 1-800 number in some public awareness campaigns, distributed it to medical providers, distributed it to community drop-in centers. Patients can call in on that line either by phone or by audiovisual connection. They can get registered through some central access lines in hospital call centers. They're thinking about also expanding the SUNS and scribes to be able to do that registration. And then much like I was describing for these other programs, they can then have a real-time telehealth encounter staffed by providers from the emergency department, from FQHC, from addiction medicine. They can do that history and intake, and then they can provide that same-day prescription for patients to do a home start and then follow up at a community clinic. So next slide. So those are just a couple examples, and I'll also throw in there, I've been hearing just in the last 24 hours about some innovative programs out of EDs. So those programs I was talking about were essentially based out of outpatient clinics and able to do outreach and do that telehealth. Some of our EDs are now offering telehealth triage as well and offering buprenorphine initiation through that telehealth, or at the very least, offering telehealth follow-up for patients who have come in through their ED. So patients who have already been registered, already gotten emergency Medi-Cal, those folks can then get telehealth follow-up by the ED providers. All of that will go into much more detail on the next training on 519, but I just want to kind of plant that seed that I think we need to be reaching out in different ways to this patient population than what we were doing before. And I know many of our medical directors, many of our hospital CMOs are nervous about this stuff, are saying, you know, I need to focus only on COVID-19, and why am I really thinking about people who use drugs right now? And the reality is this is a population health issue. Sheltering in place only works if you can stay in place. And if you have an active substance use disorder with really significant withdrawal and you need to seek drugs or alcohol, you can't shelter in place. And that increases the risk of COVID-19 transmission. And we also know that these delays in care that patients are facing, where they might not be seeking addiction treatment now, are going to lead to long-term increases in mortality. Next slide. This is a slide that I wholeheartely endorse having stolen, essentially. So this is something that I reappropriated from the Journal of Hepatology, but I thought was a really nice framework for us. And you can see the citation. We'll share these slides afterwards. But what they've described is that essentially in the setting of cirrhosis, we're going to see 3 different waves of mortality as a result of COVID-19. So it's not just about the COVID-19 related deaths. And I think we're going to see the same thing for substance use disorder. So we're seeing right now this first wave where we're seeing decreased intake to addiction services, postponed visits, decreased presentations for withdrawal. So people with substance use disorders aren't getting treatment right now. And so they're having increased rates of withdrawal-related mortality and overdose-related mortality. Once the physical distancing policies end, we're anticipating seeing a big surge in patients who are seeking treatment because they weren't able to access it before. And so we're anticipating that our healthcare systems might be overwhelmed by this surge as well. And there's also going to be a lot of patients who waited a really long time to get treatment for the complications of their substance use disorder. So maybe they had a bad cellulitis and they really let it fester because they were afraid to come in. That's going to be a second wave of morbidity and mortality. And then this third wave, the concept is that patients aren't going to be detected early with their substance use disorder. So we're missing these early interventions and we'll see a steady rise in morbidity and mortality as a result of that. So all that is to say that what we do now in terms of outreaching to these patients is going to prevent each of these waves of morbidity and mortality. And the more we can keep our patients engaged with our system now, the better off we're going to be. Next slide. So we'll go into this much more on 519, but just to think briefly about outpatient linkage. So we've talked about some of this before, but because many of our outpatient partners have decreased access right now, we're encouraging our ED and inpatient providers to think about themselves a little more as an outpatient person than what we would usually do. So that involves, if a patient is open to it, if a patient thinks they can safely keep a longer supply of their meds, actually prescribing a 14 to 28 day supply of their buprenorphine. Consider actually obtaining a urine tox. And this isn't something that we usually recommend that people do out of the ED, but in this scenario where they may not be able to follow up in person, that can be really a huge help to the outpatient provider if you can obtain a UTOX initially on presentation. In some cases, we're seeing in some communities that it's hard to get a patient in for an appointment and that they might have to wait 3-4 weeks for that initial appointment. So some of our programs are setting up something where their sons are doing more outreach than they would usually do. Say the son is checking in with the patient 2 days after the initial presentation, but then again at a week out, again and after another week, and again after a third week. And the son is then flagging for the provider, hey, this patient is experiencing a lot of withdrawal, experiencing a lot of cravings, and they're bumping that up to the ED provider for follow-up. Many of our outpatient clinics are engaging with telehealth, and then we do know that some of our communities aren't quite yet ready to make the transition to telehealth. So there are some companies out there that are also running telehealth that our patients can access through Medi-Cal. And you can see all those available on our website. Next slide. So big picture, this is me wrapping up. We've talked about social distancing, but really what it needs to be is physical distancing and social embrace. So I am not in the same physical space as you, but I am next level reaching out to you to make sure you feel as supported as you possibly can. We need to be increasing access for our patients to the treatment of substance use disorder. And we also need to be really leaning into harm reduction, making sure that patients have access to naloxone, to safe consumption supplies, that they're thinking strategically about what to do if they have to use by themselves, and that we're protecting ourselves and our sons as caregivers. I want to just put in a plug. Tell us, we are starting this virtual learning series. We've put together a lot of resources on our COVID-19 website, but we also want you to be telling us what it is you need. If you go to the next slide. Oh, I did not appropriately post it, but if you go to bridgetotreatment.org/COVID-19, all of our resources are posted up there. Thanks, Sarah, just put it in the chat box and there it is. If there's something missing from there, if there's something you want more information about or you'd really like us to delve into on the next webinar, let us know, put it in the chat box, reach out to us, email us. We're really trying to work as quickly as we can to support you with whatever needs you may have. So that's it for me. I don't know, Elizabeth, do you want to do some Q&A now or do you want to do it all at the end?
Yeah, we are going to have ample time at the end for Q&A, but I would love to hear from a couple of our hospital champions right now, whether some of the themes that Hannah shared resonated or whether you've had additional experiences since you filled out our survey that you want to tell us about. Anyone, you can use the raise your hand function. You can put something in the Q&A and we'll see it. Don't be shy. Pretend we're in one of our nice training rooms and everyone's jumping up and down to talk to us. Okay, let's see. All right, let's hear from Maureen in LA. Maureen, you're unmuted. And Leslie, I've got you next.
Myself. Hi, can you hear me?
You are. Yes, we can. Good morning.
Excellent, thanks. Yeah, so we're considering, or at least for my ER, I would like to consider doing these virtual visits. We're in the process of making some business cards that we're going to be passing out to our local EMS stations. We've done some education of paramedics on buprenorphine here in LA County, but we want to basically reach locally the EMS stations that are around our hospital. And the plan would be, just as kind of you described, the patient or a friend or a family member could call our son during business hours. We would remotely get them registered and then arrange for a telephone follow-up with the provider that's on call for that day or the next day, whenever's convenient for the patient, and then get remote access to a pharmacy, so the patient would never really have to come to the hospital. We've been doing remote visits through our Bridge clinic, and it seems like it's actually better than having the patient show up to the hospital. It seems like there's a little bit more compliance. We do have problems with patients not having phones, which makes phone follow-ups much more difficult. So we're working on trying to get patients better access to phones.
That's awesome. Thank you, Maureen. So I love that engaging with EMS is, I think, going to be a real hallmark of this. And then we and I think many other sites are seeing exactly the same thing you're describing, where we were really worried that telehealth was going to be a problem, that patients were going to have decreased access. And I think a lot of places are actually seeing an increased show rate as a result of switching over to telehealth, because it's just easier to answer a phone call than it is to show up in person. But I think you're also pointing out that a lot of our folks don't have phones, and that's why what you're doing to get the phones is important, but also still having a physical presence is important. There are always going to be some patients who are going to need to either show up in person to the ED or show up in person to the Bridge clinic. We have some patients who are, I think, disorganized enough that a telephone may never be a good option for them. So kind of keeping both of those options alive is great for us.
Yeah, definitely.
Thanks, Maureen. That was Maureen from all of you UCLA, one of our California Bridge Round 1 hospitals. Let's hear from Dr. Macau at El Centro, so also in Southern California. You should be able to unmute yourself and talk. You should be good. Good morning. There you are.
Good morning, everybody. Actually, this is a comment related to the question that I just sent in. We have just one clinic in Imperial County that we refer our patients to. And most of our clients are homeless patients. And what has happened, especially in the past month, is we are also experiencing a number of people coming in with overdose at a greater rate than before. Now, one of the innovations that the clinic had done in the past was actually to send a van to the parks where the homeless people usually stay, and then, pick them up and bring them to treatment. But because of the pandemic and shelter in place mandate, they've been unable to do that. And actually, we are seeing our follow-up to clinic numbers really drop significantly. And I'm noticing in the comments, someone mentioned that there are people still doing street visits. And I just was wondering how other centers are still able to do that.
That's a great question. Does anyone want to share their experience with street outreach in their communities? I think I can say that we haven't been doing this in my own community, but I've been hearing from some folks that are still doing some of that street outreach with maybe a streamlined team with good PPE, and that some of those street outreach teams are kind of bringing an iPad with them so that they can do an audio-visual connection to the provider in the clinic as opposed to bringing the patient into the clinic. So one innovation I've heard from some folks. What else are you guys experiencing out there? Maybe raise your hand if you've had an experience with street outreach. We've also had, we've been lucky enough that some of our homeless populations have been temporarily housed in hotels, which I know is happening sort of intermittently throughout the state. And so we've been doing a lot of like telephone visits with those patients, kind of calling into those hotel rooms in a way that we weren't able to do before. But people's kind of encampment in the homeless communities that previously existed have also been really disrupted, at least for us. So it's been a little harder to find people than it would have been before because they're not able to stay in the same place they previously were.
Yeah, that is a great point. I live in San Diego, and San Diego has adopted that. And I understand the state actually had money for cities to apply for that. But, you know, I'm in Imperial County in El Centro. We don't have any of those innovations in place. So the homeless people are still out in the parks and all over the place.
Yeah, that's a real challenge. Thank you for sharing that. And we're hearing that from our sons as well. Just challenges reaching homeless patients and patients who generally have less access to technology and other resources. So that's something that's been coming up again and again in our son pop-up, something we're monitoring very closely. How about one more question? I see we have a hand raised from Monique, who's our son at St. Francis. So right in Hannah's home territory of San Francisco. Monique, you should be able to talk to us. Give it a shot. Give it a pass. Monique? Maybe she lost her question. Okay, all good. Okay, great. Well, thanks so much. I see I have a couple more questions coming in over the chat. We'll keep our eyes on those and we'll return to those a little bit later in the presentation. So I'm gonna go ahead and turn this over to LaToya Mitchell, who is our son, our amazing son at Bakersfield Memorial Hospital. LaToya, can you just talk so that we can hear you? Go ahead and
yes,
unmute
can
yourself.
you hear me?
Yes, there you are. Great. And thank you, Hannah. We'll look forward to talking to you a bit more when we move toward the questions part of the learning. So LaToya, talk to us about how you stayed on site, stayed safe, and actually increased volume at your hospital.
Okay, so I'm from Memorial Hospital. What Memorial Hospital, and we're part of Dignity Health, what we did initially was we put a big tent outside of the ED to do screenings. So the first part of everything was just safety of, you know, all hospital staff and any patients who came to the ED. So then there was a quick look nurse and registration place out there to screen everybody, get them checked in, and we incorporated the universal masking, so everyone who comes to the hospital has a mask, no matter what. And then obviously, you know, the use of PPE, things like that. Hannah, you know, was mentioning some of that earlier with the goggles, gloves, masks, and disinfecting protocols. We do all of that here. But some of the changes that we did in addition to that, as far as patients with substance use disorder, is that I was being contacted more commonly from a range of different employees. It wasn't just the RNs like I saw before. I was being contacted by cell phone, through my desk phone in my office, text message, and they were directly walking over to my office to come get me or tell me, you know, give me a patient sticker or tell me who was in the Cerner tracker that needed to be seen. One of the main things that I did when the, you know, statewide stay-at-home order was kind of initiated in mid-March was I went on Bridge on the COVID-19 site to see what any and all of the information was on there, what changes were available, you know, what regulations were more relaxed, any tips that I could get. I was attending every webinar that I could possibly attend in March and April. And then days after the statewide stay-at-home order, we held a in-service training for the whole social work department. We have a social worker on all 6 of the floors that we have in our hospital. So engaging social work at that time was really a big game changer, I would have to say, for us in our hospital. I worked a lot with social work before, but this kind of re-cemented the need of all of us working together to help our patients and to prevent, you know, somebody, you know, needlessly losing their life because of not getting the treatment they need. So I was able to put packets together for the social work department to give them, you know, my contact information. They had cards to give out to patients. They had a list of all the referral sites that I use for opioid use disorder and for alcohol use disorder. And then they also had a list of the 2 main pharmacies that I typically refer to that ensure no matter what, they have Suboxone and naloxone in stock for our patients. And that's really important because the fear of running out of medication for those who are already on Suboxone treatment was very real. So doing all of that allowed me to start getting, honestly, more in-house referrals from our staff, from not just the nurses, not just the doctors, but from the social work department as well. I feel like now I have kind of this new hat that I wear, and I get more calls from the other floors, from our inpatient floors, for people who are threatening to leave AMA. I feel like now that's immediately what they do. The moment that any staff member hears a patient saying, you know, I'm going to leave AMA and they have an opioid use disorder, they leave the patient's room and they immediately call me because they want to prevent this person from leaving without getting the treatment they need. And they now realize that I'm here and, you know, I can help them. So we've been able to increase our number of new starts for buprenorphine and for methadone on the hospitalist side of things, not just in the ED. Let's see. So I also contacted every single one of my landing sites. So all the referral sources that I have, I contact all of them. I stay in contact with them on a weekly basis so that I'm aware of any changes that they're going through. If there's going to be a delay in the admission or intake process, if they need to be cleared first. Some of the residential programs are requiring clearance of COVID-19 before they'll even take anybody, things like that. So for me, knowledge is power. The more that I know of what those changes are in the community, the better able I can help our patients get into these programs. The fortunate thing is that many of them, many of the MAP programs, because they did go to telehealth, we were able to get a lot of next day appointments. So it actually decreased the number of prescriptions that our hospital needed to write. But if we did need to write prescriptions, then all the X-waiver providers that we have were on board with writing prescriptions for longer durations of time. We were seeing more 7 and 14-day prescriptions written, and under special circumstances, even 30-day prescriptions. Let's see. If the patient wasn't able to start buprenorphine in the ED, or they chose not to, either because they didn't disclose their opioid use disorder, or they, didn't think that they would need it, or maybe thought they weren't ready to start a medication like that. Once they got to the inpatient side, then they would realize, hey, I'm sick, I need something. So I saw an increase in providers that I hadn't actually dealt with in the past that were more open to discussing starts of buprenorphine and or methadone. So that honestly, it just really warmed my heart and humbles me to no end that I can see these increases in just providing care, but also the number of people coming to get treatment.
Yeah, thank you, LaToya. What an amazing story. One of the reasons we wanted to highlight this story is also thinking about that this might not have been a one-time occurrence, right? If you listen to Governor Newsom and his updates, we're hearing that there might be several more rounds of these sheltering in place until this epidemic passes us. So I love LaToya's story because it shows you how this model can work without, how our model can work without completely disrupting the Sun's workflow. Amazing work, LaToya. Thank you.
Absolutely. Thank you.
Yeah. So we'll definitely have time for questions for LaToya and also for Marla. So I'm gonna move us along to another possible way that this could have worked for a site. Turn this over to Marla, our amazing son who's at Santa Rosa Community Health Center. Marla was a very early adopter of this model. She's been working in this space for, a long time, and she's been really invaluable to us as a resource for how to support the sons. So I'm excited for her to tell you about how she used creativity to also increase the patients who she was seeing. Marla, go for it. Let me know when you're ready for your first slide.
Yeah, hi, I'm Marla Full. I want to thank you, Elizabeth, for that super soft landing. I've never heard an age reference that could go sideways when you're referencing how long a person has worked in the field land that softly. I've been doing, I was in methadone for almost 10 years and have been doing this a total of 15 now in buprenorphine at a FQHC community clinic, the largest FQHC in Sonoma County, Santa Rosa Community Health. And gosh, a long time is just such a soft landing. I super appreciate that. So
we've been very grateful for your expertise at the Bridge program.
Thank you for that. And I'm always excited to do this work, and that includes right now during this COVID crisis, because it's been a part of my approach to care in the OUD field to recognize that this is a modality of care born in crisis. And I think that if we lean into whether we be providers, which I am not, I'm not a clinician, I'm a drug counselor by certification and now a grant writer and program, MAP program director for our FQHC. But whichever way we come into it, I think it's so important to remember that we are, and especially our ED providers, we are born into the crisis. You guys are experts at functioning in crisis. And if you'll bring up that first slide, I like to think of SUNS as experts in getting people where they need to be. And so it's very much what we do, I think, is very much about getting people where they would like to be and bringing the resources to them that they need. And from Jump Street, under the very best of circumstances, folks struggling with OUD may in some nebulous way have a vision of where they would like to be, but they absolutely need that support. And I use this imagery in lots of different ways. I see it now as our providers need our support as well. We've got to bring our hospitals some support. And so the way I would say it is important to note that I work at an FQHC. So I have a partner in Diego Tucker and Dr. Omar Ferrari. Dr. Tucker and Dr. Ferrari are at Santa Rosa Memorial Hospital. Their ED and their in-house son, who is my partner in crime out here, is Alexis Bucio. And in fact, Alexis just made a shirt. Hers says on the front, "I can help get you off of opioids," and mine says, "I can help keep you off of opioids." And on the back of our t-shirt, oppositional pointing arrows say, "I'm with her." And I think that's the core of how we have grown resilient in this particular crisis is, believe it or not, our folks are hesitant to come into the ED themselves, afraid of becoming ill. And so we have, I am not out of the clinic. I know Alexis is off site now. But what we have done is we've utilized at Santa Rosa Community Health increased collaboration with a couple embedded folks that we already have at the organization. And one of the most important ones is our insurance navigator. And so she and I head out to the encampments and to the homeless centers. And recently we've been at speaking at drug treatment facilities, even those that are abstinence-based, kind of carrying the message and making sure that people are insured, so that that's one less thing that has to happen at the ED. The bottom line is that what we found is that our people, our patients, boots on the ground, are our best promotion. And they absolutely spread the resource word and let one another know what is available. So we've been heading out using our phones, helping people get set up to do audio-visual visits with providers, both with us and with Alexis, so that rather than the ED or Alexis on behalf of her ED reaching out to us and saying, "Hey, we have someone here," I'm also reaching out to Alexis and saying, you know, "Hey, can you help this person in a crisis?" Or, "We just got this person insured. We want to make sure that our hospitals are receiving people in as efficient way as is possible." So the phone has been a big deal, and the new iPads have been a big deal, making sure that folks know that this workflow is established now. It's not this a frantic thing. They are welcome in the ED, and I am willing to go with them anytime, and Alexis is willing to meet them anytime. Alexis has also gone with me to Sonoma's homeless shelter, the tiny shelter out at Los Guilicos Juvenile Hall. So those field visits are huge. They're important. And we let people know that we want to tell their friends, whoever they are, that we will come to them and help them with insurance navigation, and that they don't have to necessarily wait for that, but that's something we can make happen today when we're out in the field with them. As far as what we're doing with our ED Bridge folks that we are maintaining on maintenance medication, we developed a thing called field and park visits. And the field visits, we also call them drive-up visits. And that's where we reach out to one of our patients, let them know, arrange a time with them when we can come by as their case managers and counselors, and we drive to their house and clarify with them before we pull up, you know, our concern about any HIPAA stuff. We're not going to be asking them anything especially clinical at all. This is really just a time to let our patients know that we're still with them. And that's been amazing to then pull up in front of someone's house and them open the door. I can't tell you how in shelter in place, how stoked they are to see us. And so we've had a lot of things. One of my counselors shoots them candy bars with a wrist rocket up onto their porch or wherever they are. And we are literally just trying to be as visible as possible. And so what that means is we've flipped the script so that rather than hoping and waiting that they come to us, we are going to them and reminding them of what we are doing, and that the hospitals around them are supportive of us, and that if they hit a glitch or a bump, I'm available, Alexis is available, and Alexis is available to represent her hospital. And she is a direct connection to getting in there. And for them to know that, I give all of our patients, Alexis says, this is pretty nice. I don't know that I think I've told her this, but I've never waited to find out how much she appreciates that I've given her a phone number out to as many people out there on the street as I possibly can, and just said, don't hesitate to wake Alexis up. And she can get you connected over at Memorial Hospital. So we've changed the way we are communicating with our patients. The other thing that I always want to point out is about Narcan. Our docs give our patients, automatically give them Narcan, and we give them automatically free refills, no questions asked. And I just encourage our patients, get one today and go in, no questions asked, pick up another one tomorrow, give it away to whoever you would like. And Alexis and I are getting ready to do a promotion for that called Get Ready to Be a Hero, Ask for Narcan. And so those are a couple of the things that we have going. If you could, I'm ready for that next slide, and then I'm going to quickly get out of here altogether. Most of you, I'm sure, will recognize who this is. That's, of course, Muhammad Ali. And for those of you who don't know, on the mat there is Sonny Liston. And in speaking to the other sons about seeing every crisis as an opportunity and seeing our work as an opportunity to not just help individuals, but to change the language and the tone in the culture and to normalize this modality and integrate it into primary care and emergency care that can then be directly connected to maintenance. I always want the sons to remember that their greatest strengths are their education, and that they can step forward confidently in the ED, being able to both balance that sense of when it's important to step back and let the clinicians handle the important work of a medication first model, but being available to them in confidence with what we know and when to step in. That last picture, the story behind that is that when Muhammad Ali was much younger, he recognized in a spiritual awakening, he referred to it as a moment of clarity when he himself recognized that the name he was born with, which was Cassius Clay, was not his true name, but rather what's referred to as a slave name. That Clay would have been the name of the folks who first took ownership of the human beings in his family before him. And he then, in that moment, decided he did not want to be known as Cassius Clay and took on the name that we all know him by, Muhammad Ali. The fellow there on the floor, again, is Sonny Liston. And at that time, Sonny Liston took great personal offense to that and used it as a media moment to chastise Muhammad Ali, saying that he was disrespecting the sport and he was drawing too much attention to himself and that he was disrespecting his parentage. And it took Muhammad Ali 19 months of actively seeking a fight with Sonny Liston after that conflict began for him to get that fight with Sonny Liston. And I want to point out that this is the first minute in the first round when he finally got that fight with Sonny Liston. And you can't see it, of course, in this still shot, but if you were to YouTube this grainy black and white film of that moment in that fight, above the outrageous cries of the crowd and everything, you can not hear, but you can almost read his mouth. And he is famously screaming to Sonny Liston, "Say my name." And I want to remind all of the sons that are out there, and I want to thank the providers who are doing this important work, that it's our opportunity, our privilege, and our great opportunity to find our patients where they are, whether it be in the homeless encampment during this crisis or in a shelter or in a park, and ask them what they would like us to call them, and to remember that all of our folks get to find that name, and it's our opportunity to bring them to care and to sustain them in care. I'd like to thank all of you for giving me a chance to chat about what we're doing differently at Santa Rosa Community Health, and that's it.
Thank you so much. What an amazing story. Thank you, Marla. And I also want to say to all the sons on the line that we will look into ordering those t-shirts that Marla and Alexis have for all of you for your next training. So you don't have to inundate us over Slack and ask. We will let you know how we can get you those t-shirts. And Marla and Alexis, when you are able to be together again, we do insist on seeing a picture of you wearing those shirts, front and back, please. Thank you so much. See, Latoya says, I love the t-shirt idea. Oh, now we have to do it. All right, Christian, Vanessa, hope you're listening. Okay, great. Well, we have a couple of minutes to take your questions. Would love to hear from any providers on the call who want to respond to anything they heard from Marla and Latoya. Are you inspired? Are you, just is your head spinning for how you can incorporate some of these ideas from these two sons? And while I give you a chance to put your hands up, Hannah, I'm looking at you. Everybody's just excited about t-shirts. I get it. We'll work on that. So Hannah, we had a question come through from Cindy at San Gregonio, who had a question via her champion. It's a little bit nitty gritty, but it's something that's actually come up a few times. Yeah. So I'm going to go ahead and read that out. And Cindy, I'm going to make sure that I got it right. And I'm going to go ahead and unmute you and allow you to talk if you want to contribute. So Cindy asked, how can we get a patient registered in the system if they don't come to the ED and we want to refer them to a MAT clinic? What exactly would the provider write in their note? Cindy, did I get that question right? You should be able to talk. You should be able to unmute yourself and talk.
She says,
hey,
ask Dr. K.
It's actually me, Dr. K.
Hi.
I think we're sharing our Zoom. So
great. Cool. Nice to talk to you. Nice to hear from you.
Yeah, you too. Thank you. Yeah, so basically, like, I'm just having trouble. So say we have a patient that we've never seen before, and Cindy has a connection to the patient. We know we need to start them. We'd like to home start them, but I don't have any information on the patient, and I can't write a note. So I know just writing a prescription, I can't just do that. But I need to register them somehow. So I'm not sure, like, dealing with the logistics of the hospital. Like, I love that the patient didn't have to come in and I could just talk to them. I'm comfortable with that, comfortable with the prescription, but I feel like I need to have a note for that encounter.
Totally.
We have great follow-up, but I just don't know how to start it. So I've been saying, at least they have to come in and just register. And, even if I just see them for a moment or see them on the telemedicine, I'm willing to do that, but I just don't know logistically how to handle that.
Yeah, so every hospital is doing this in a little bit of a different way. So it's hard to say exactly like the nitty gritty of logistics for you, but I'll say that many of our hospitals, and we can connect you directly with folks who are doing this, are essentially having a mini registration workflow where either the provider can gather like really basic information about the patient, including like their name, their date of birth, and maybe their insurance information. And then there's like a workflow through many hospitals where you can do that mini registration and then open an encounter for the patient. Some sons have actually been trained to do that, so they can open an encounter for the patient. And that can either be done through the emergency department or through an affiliated outpatient bridge clinic. But you're totally right. You do need to register this patient either yourself through a mini registration workflow or in partnership with an eligibility worker at your hospital, or a scribe, or whatever your hospital workflow is going to be. You do need to register the patient. You need to open an encounter and write a note so that you can have appropriate documentation and coverage for yourself for the medical work that you're doing. And we have a couple resources posted on our website that kind of talk through some of these workflows, but every hospital, you'll just need to kind of check in with your eligibility workers and see if there's a way for you to either do that mini registration system or have your clerks kind of pop the patient into the system.
Perfect. And then we can just do that over the phone with the patient, right?
Yep. That's what most of us are doing.
Awesome. Okay, good. Because, yeah, awesome.
Thank you so much. It's nice to talk to you.
You too.
We are very close to time. I'm going to run through these last couple of reminders, and then if we have one or two more questions, maybe we can take them just for a minute or two. So again, 2 weeks from now, we'll be doing the same format of training. Any feedback that you have, send me an email, Elizabeth Keating. You should all have my email. Reach out to your regional director. We would love to know how to make these trainings valuable for you. Again, some pop-up trainings are coming up. We also have our conversation series, which is a little bit more of an informal way to talk to our clinicians. We have a curriculum survey for a little bit more feedback on our very formal materials that will be used as our program expands. The Get Waivered free complete X-Waivered course is on May 20th. Amazing opportunity to use the bandwidth of providers who want to get X-Waivered while volume is a little bit lower at your hospitals. And then finally, we are supporting the ASAP Equal Online Learning Collaborative, which is a really good opportunity to continue to share what we're doing with Bridge nationally. This is our COVID resource page, and we're happy to take another minute or so for any questions or additional response to Marla and LaToya or anything Hannah said. Anyone else want to chime in?
I'm seeing a question in the Q&A box for Marla. Is the Sun phone number available publicly to the community?
Yeah.
Awesome.
Yeah. Yeah, my partner loves it. That's true.
You guys are rock stars.
Yeah.
And then I'm seeing a question in the Q&A box about there's a cures carve out for EDs to write a 7-day non-refillable narcotic script. So this is true. If you're writing more than a 7-day long prescription, the current regulations do state that you need to check cures. So that's a change in workflow for many of our ED providers. We know it's a pain in the behind. I think it's worth it. Just check the cures report if you're able to, and then send that longer prescription if that's appropriate for the patient. But talk to the patient in front of you. Some patients don't want a month-long supply. Some of my patients say like they don't feel comfortable holding that much. They're afraid about it getting stolen. But if you do have a patient who feels comfortable taking that longer supply, please do check the cures report and write them for that longer supply so that they don't have to bop back and forth to the pharmacy on multiple occasions and risk that exposure. We will check in with our contacts to see if there's anything that can change about that. But for right now, the regulations do state that you have to check the cures.
If I can interject something about cures really quick.
Mm-hmm.
The provider can add their son or whoever else that they want onto their cures, like as a, I don't remember what it's called, but they can add them where that person has their own login to go and check the cures and print it, and then give that to the provider, kind of just save time so they can just review it before writing the prescription. Sometimes it's a matter of you know, just timeliness. So if I can, you know, do that part and you know, take it off the hands of the provider and just bring it to them so they can review it, then it's a little bit of an easier process.
Great, thanks for that. Great. Okay, great. So yeah, a couple.
I want to just throw in this just came in through the Q&A box, and this is my interpretation as well. You can be put on as a delegate if you're not the provider, but you actually do need the provider themselves to document in some way that they have checked the cures, and in some systems they actually need to check the cures themselves, but you can push the cures report to the provider's dashboard, which saves them a step. But just the son checking the cures, at least by many hospitals' definitions or interpretations of the law, might not be enough. You might need the provider to directly do it with the son's support. Just to complicate things further.
Great. Well, thank you, everyone. We will be sending out these slides along with a short, you know, a couple questions of feedback if you want to give us any. And we're really excited to continue these. We have a Sun training next week that's going to focus on some of these best practices we're hearing in terms of returning to work in the hospital. It's also going to focus on some of these the details of some of these clinical options beyond your basic buprenorphine that I know a lot of you have questions about. So we'll be bringing on our clinical experts to talk to you. And then 2 weeks from today, we'll reconvene to talk more about the nuts and bolts of telehealth. So thanks very much. And I just want to call out, we have a new son who we had a question on the chat that we didn't get to, and we'll reach out to you to make sure you get the support that you need asking about the AA meetings, Robert. So we'll talk to you soon. All right. The sun training is, the next sun training should be on one of these slides. Let's see how I did. That's the next sun training, May 14th at 11 a.m. We'll make sure you get that link. Thanks for asking. All right, everyone. Have a great rest of your day. Be in touch with us with anything that we can do to support you, and we look forward to continuing to all work together. Have a great day. Bye.